over that one. All right, thanks, Quentin. Hey, everyone. So I hope we've all had a good day. I have learned how to ski today. So 45-year-old man with some very sore legs, and that's absolutely fine. This is my second time doing this talk. Apparently 10 people have returned from Queenstown. So for those 10, I apologise. For everybody else, you can bear with us. When Quentin asked about this talk, I thought it was kind of hard to pitch a paediatric talk. It's also going to be hard to say without swearing, but there's little ones here, so I'll do my best. I thought about, where do I pitch? If the audience is roughly a third, doctors, ambulance officers, and nurses, where do you pitch it? And I think actually it's really easy. If you don't work with kids every day, and if you do work with kids every day, you're generally terrified of hurting one or killing one. So this is basically an idea of how not to do any of that. Queenstown was 40 minutes. I've got, okay, probably closer to 40 minutes again. We're going to go through this. I can add a little bit of trauma this time, but mostly this is an idea of how do you get the vibe? You know, how do you have the experience or just the radar of a 20-year veteran in paediatrics to know which kid is about to curl up their toes and pass away on you? And I use different words for that time. What's your name? Nice to meet you, miss. Yes, sir.
Feel free to speak, but used a very colourful language.
Excellent. I'll still try and exercise some restraint, but if it slips out, I apologise in advance. Okay. Whenever there's only really 3 main points that I would like you to remember, and each of those points I'll mark with a golden balloon dog. Okay. When I first became a consultant many years ago, I was obviously terrified of this exact thing, whether through action or omission, being responsible for killing a kid. So to try and deal with that, morbidly, I downloaded and binge read about 25 paediatric coronial reports. These are reports and reviews of children who have died. And that, although horrifying, was probably still one of the best things I've ever done. So if you have an end career in paediatrics, I would... Cool. If you want a career, I still recommend doing that. To update it, there's another document which I have with me. If anyone would like a copy, it's superb. It's from the COPM group, which is a Victorian government entity, and it's a summary document of almost every coronial or pericoronial file that they've got, and it's an extraordinarily summary of just basically 24 pages of how to properly take care of kids, from the acute to the less acute. But if anyone wants a copy, I'm happy to give this out at the end. I'm not affiliated, I just think it's really good work. Okay, so which kids? Because we know kids can die for lots of reasons. There's SIDS, there's oncology, there's trauma. This is not about those sorts of things. This talk is going to be about the kid that you are going to have in front of you, who's still breathing, possibly still talking, but might not be for too much longer. So how do you pick the kid before they end up in this? This table is an Australian table. It's based on the Australian Institute of Health and Welfare data. It's from their GRIM book, which is the General Record of Incidence of Mortality. If you're ever in charge of large data sets, please don't give them clever names. GRIM is a rubbish name. The other book is the MORT book, which is Morbidity over Regions and Time. Don't do that. All right. If you break it down, there's still in each age group, neonates, little kids, bigger kids, adolescents, anywhere from 20 to up to 50% of these kids, the other. These are the ones that we are going to have in front of us. So this is the talk to try and help us figure out what we can do. And we can do things to help these kids. The malignancies, the congenital anomalies, these ones, obviously, I haven't got the skill sets to deal with any of that sort of stuff. Okay, are there any residents or registrars in the audience? Excellent, young people at the front. I have too much respect for our ambulance colleagues, and I'm never going to pick on a nurse. So, what was your name? Yeah. Yeah. Naomi, correct. Okay, Naomi, can you just point to that light for me, please? Nice and high. Now, no, high, really high. There we go. Now, I do need a volunteer. Oh, Naomi, thank you. Can you tell me what these images represent? We have a Goodell airway, and then the lungs for breathing, fluid for circulation, A, B, C. So it is a... yes. Put them all together and this is a system which is the primary survey. Easy. This is all we actually need. This is our core stuff. This is basic stuff. But this is the stuff that you can apply to pediatrics in a really excellent way. I'm going to just... What is the point of a primary survey, Naomi's neighbour? What's the point of it? Why do we do it?
It's a rapid standardised assessment.
Looking for... So to everyone in the back, it's a rapid standardised assessment. Perfect. Looking for?
Imminent danger.
Imminent, to identify and manage life threats. And that's all we need. We know what a primary survey is. We know how to apply it. We can apply it to paediatrics very, very, very well. The best way to annoy a paediatrician is to say that children are just little adults. That absolutely gets our blood pressure up and it's fine. But this picture, I think, is the best illustration of why paediatrics is special, why children are special, and why adults, they've had their time, doesn't matter about them. So, a normal adult skull on the left, a child's skull on the right, and a baby skull in the middle. Imagine the difference of airways between those three and how you manage them. You don't have to imagine too much, and you do not need to memorise this list. They might have a large tongue, they might have a high anterior cricoid and a narrow larynx. And if it's a baby, you've got a 6 to 7 millimetre lumen. So if you have even a millimetre of edema, you've reduced the lumen size enormously. You don't have to remember this list at all. Hell, I don't. But just try to remember the picture to realise that I am dealing with something different and I can make some allowances for that. The one big allowance, if you've got a child with an airway issue, maybe they've got a stridor, maybe they are obtunded in some way, don't place them supine on a trolley like you would do an adult. They've got a giant head and a little body. If they're obtunded and you put them flat, that head's going to roll the head forward and obstruct the airway. So you can see whenever we're doing a resus, we've got boards underneath to raise the thorax and keep the airway in the neutral position. An adult, to maximise airway, you want the sniffing position, a bit of extension of the head and neck. Paediatrics, that'll occlude the airway. We just keep them neutral, and to do that, we just have a little flattened towel underneath them. All right, so with airways, this is just recovering the basics, what I didn't get to do in Queenstown. Basic airway manoeuvres are still valid, a bit of jaw thrust, a bit of chin lift, of course. Bag valve mask, 100% oxygen, always. Advanced airways, this is not a talk about that, but it's always valid. All right, little bit of B and C. We're sticking with the primary survey. Respiratory, there are some basic changes. The diaphragm is the absolute dominant muscle of respiration in a child. They've got basic higher respiratory and metabolic rates, and they've got a far more compliant chest wall. They will have massively pulmonary contusions before they ever break a rib. And for circulatory, I'm going to terrify one more resident, I'm sorry. Yeah, you're looking away. How do you calculate cardiac output?
Cardiac output is heart rate times by stroke volume.
Heart rate times stroke volume, perfect. Children have got near bugger all ability to change their stroke volume. So their output is dictated by their heart rate. If the heart rate wobbles, pay attention. All right, the main threats to life in children is circulatory shock, catastrophic bleeding. All right, so these are the basic key takeaways of the primary survey. I know we know these, but it's worthwhile going over them again because we're going to get to the main point. So how do you pick a kid? You don't need special skills. And like I'm saying, the point of this talk is actually to introduce very little new knowledge because we all know the primary survey back to front. It's easy, it's alphabetical. You don't need to memorize facts about Neisseria, meningitis, about RSV, bronchiolitis pneumonia. All you need to know is the stories. And human beings are storytellers. This is Palmyra. This is a ruins in Syria, an ancient Roman ruins, and a massive theatre because we are natural storytellers. I mean, especially healthcare workers. How many times have you started a story with, I had this patient, I had this kid, I had this adult who? We learn by stories, we communicate by stories, we tell each other stories. We are natural storytellers, and all we need to do is listen to the story of the child, and this is where you're going to find the problems before they become catastrophic. We have been storytellers for generations. These are the Chauvet caves. This is one of the oldest cave drawings in the world. It's about 35,000 years old. As a species, Homo sapiens, sapio means wise because we learned to assimilate knowledge and communicate that to the next generation. We can just basically lean on our intrinsic ancient DNA to get the ideas to fix and find these kids. The oldest cave drawings are in Indonesia, I want to say, in Liang Karampang and Sulawesi in Indonesia. These are about 50,000 years old. So we have 50,000 years of experience that we can bring to the kids. These are two of my kids. The big butt went boom. And my then 5-year-old, which was where the crabs are. So my children apparently will be colorectal surgeon and sexual health worker. But you only have to listen to the story. So why is the story important? I mean, what's the basic story of a cold? What makes kids sick? You have a cold. What is the story of a cold? You don't have to memorize all the pathogens, RSV, human metapneumovirus, rhinovirus, but you have a cold. So you have a runny nose, cough, sore throat, fever for about 3, maybe 4 days, and then you slowly get better. When a kid doesn't follow that story, when the story doesn't make sense, that's when you start to think. So what are we going to think of? There's a little bit of content here, but you don't have to merely remember any of it. The first thing that will kill a kid, and that you can actually have a chance to intervene positively with, is going to be sepsis. It seems obvious, but this still keeps coming up. I'd say at least half, even more than, of those corona reports that I read were children who passed from sepsis, and there were times in the report that you think we could have done something differently. So what is sepsis? Sepsis is overwhelming infection. We have WHO sort of definitions. Basically, it's an overwhelming immune response to a significant pathogen. It's cardiovascular dysfunction with the need for fluids plus minus inotropes. Okay, I mean, these are the definitions, but what do we do? Why is this meaningful? A lot of these pathogens we do know. We know about strep pneumoniae, we know about Neisseria meningitidis. In Australia, 2017, our 12-month vaccinations changed from being Men-C to the quadrivalent meningococcal ACWY. So rates of Neisseria have absolutely plummeted. The last case I was even aware of was a teenager. Neisseria actually has a bimodal distribution. The first is in the neonate, in the small population, the under ones, and then again in the teenagers when they start snogging each other. Don't ask me what that means. All right, the thing to probably recognise, especially with the post-COVID and pediatrics, the post-lockdown, is group A strep, or an invasive group A strep, IGAS. This has been a real nightmare that's slowly calming down. We had a massive outbreak in England and Australia of invasive group A strep after lockdown, not to do with COVID, but to do with lockdown. And why? There were 3 theories, and I believe that all of them were correct. The first is that when we were all in lockdown, we weren't going out and doing what we were supposed to be doing, eating dirt, licking windows, all those things that kids do, sharing germs. So the rates of general strep transmission were low. There was less impetigo, less strep throat, less immunoglobulins flying around the community. So when we came out of lockdown, they got sick far more easily. The same theory is true for every other infection. I mean, if we've all worked in healthcare after lockdown, the amount of flu, gastro, HMPV, COVID outbreaks, everything went huge. So everyone was sick, especially the kids, with all sorts of illnesses. And so strep was appearing more often, but it was also appearing more often as a secondary infection, so a pneumonia or an empyema. And the third theory is that there is actually, unfortunately, a new strep bug called the M1 UK. So we can blame the Brits for that, and there are a few here, which was far more prevalent. It had about 5 times the virulence with the endotoxin. Pertussis causes horrendous problems. You can get white cell counts into the hundreds. And in resource-poor settings, diarrhea and pneumonia are still major threats to life. So sepsis is something to think about. But when do you think about it? What does the child look like that's going to make you think about it? There is a little bit to the age. And again, it's just the story of the kid. A little baby an infant neonate is not going to tell you what's wrong. They're not going to say my throat hurts. They're not going to say, oh, I started with a runny nose. They're just going to look vaguely unwell because babies are just lovely but vague little creatures to begin with. So a baby will look vaguely unwell. An older kid will often have sort of slightly more signs. Apnea is a horrible sign in a neonate. It can be an RSV, it can be a sepsis, it can be a congenital cardiac or neurological thing. But the older you get, the more you're actually going to show the signs that we're a bit more familiar with, that you can actually put into the A, B, C, D, E, because this is all just primary survey stuff. I still don't bother to remember cold shock and warm shock and how to really tell the difference. If you asked me to rewrite this slide out, I couldn't do it. The one thing to remember is that there are versions. So even if a patient is normothermic, they don't have a fever, and they're not hypothermic, doesn't mean that they're not potentially sick, because they'll be moving between the two. They could be hot or they could be cold. What are really relevant to humans in general, but little kids? I would say unexplained pain in an unexplained irritable child. Like they're sore in their muscles, they're sore everywhere, but there's no obvious trauma. They're not particularly infected in one site versus another. Grunting and tachypnea. Children who grunt are children that we should pay attention to. Grunting is just one of those signs that keeps coming up again and again. No one sign is specific. No one blood test is specific, which is why sepsis is so hard to practice, it's so hard to teach, it's so hard to get right. The more signs you have, the more likely you are to be showing that you're actually in trouble. And I know it seems trite, but this is actually evidence-based. Don't ignore the parents. If the parents say, my kid is sick, you said, yep, that's what the last 10 parents said, and they all had colds, and they're all running around happy. But if the parent says, my child is sick, they're normally running around. They're really, really flat right now. I bought them McDonald's because they're sick. I want them to eat something. They still didn't eat their Maccas. That's a big red flag. So in an evidence-based, parents usually are right. Now the sensitivity, the specificity is low because so many parents think their kids are sick, and they're not wrong, but they're not right in this context. But if they are worried, then you worry. Height of the fever, I just wanted to talk about because there's so much hysteria about fever in general. We're actually going to talk about fever tomorrow a lot when we talk about how to communicate with parents acutely. But we went through a phase of fever bad, fever is still bad. We went through a phase of it doesn't matter how bad the fever is, hot is hot. And actually that's not true. Unfortunately, if you have a temperature over 39, there is a slightly higher risk of having an SBI, a serious bacterial infection. It's not uniform, 4 out of 5 times they're still going to have something really benign. But it just is a reason to have more thought. It's having it about thought. And the temperature should be done ideally the gold standard way, which is axilla or rectal, so it's always axilla in our culture. The forehead zappies are basically random number generators in most of our minds. Over 41, half can have a really serious infection, which still means half cannot, but we do just have to pay a little bit of attention. And the other thing which I haven't talked about is fever for more than 5 days, because fever for more than 5 days doesn't really fit a story of a benign infection. Again, think of the cold. You're sick for about 3, 4, 5 days, but generally you're not feverish on day 5. So fever on day 5, and there's all these guidelines about day 5 of fever. Fever on day 5 is another point to stop and look at the kid. There's still a very high chance they're having a benign infection they're going to recover from completely, but there is statistically a much higher rate of having an issue if the fever's on day 5. This is all confusing and hard, and it's okay to cheat. It is okay to cheat in every single way if cheating means reducing your mental load. This, I would advocate taking back to every health service that we all work in. I'm trying to adapt this for my service. This is called the Sepsis 6. It is brilliant. It is an NHS spearhead. It is 6 simple steps. Tick them and sign them, and that way you don't have to stress about it. Just absolutely keep it as simple as you can. You don't have to fix everything. You don't have to do anything heroic. If you're in this state where you're doing something heroic to save a kid, it means the systems around you are not working, because we don't need heroism. We just need consistency and safety. All right, so sepsis can kill kids, and myocarditis can absolutely kill kids. Viral myocarditis, so a viral infection that affects the heart muscle. Obviously this one's affected because it's turned grey, but on the whole, this is the rubbish that keeps paediatric specialists like myself up at night. This is the true needle in the haystack. These are the kids who just look a bit virally. They have a bit of a runny nose, maybe a temp, often not. They're a little bit flat like every other kid you've seen for the last 3 weeks. So why are these kids different, and how can you pick them? Well, we can actually work on the gestalt. Historically, we only recognise myocarditis cases at autopsy, which tells you how morbid and serious this is. For a time, we had a crack at biopsies, which are horrendous. If you didn't get the right bit of tissue, you had a normal result, so the sensitivity was low. Having a normal test did not rule out the diagnosis at all. And if you had it positively, you've got it in a really invasive way. So with a bit of this, we went back and we just went on clinical criterion, which are nebulous and horrifying. Now we have a bit of cardiac MRI if you work in a fancy centre. Myocarditis can come from any sort of style of agent. I've seen it from RSV, which is what gives us a bit of respiratory infection. I've seen it from flu. The one notable pathogen that's not on this list is COVID. COVID did a number for that as well. So anything can come, drugs can happen, all of these things. How are you going to pick it? Like, why does this keep us up at night, and how can we try and pick it? Just go back to the basics. Let's go back to the primary survey. It's a myocarditic feature. It's the heart. It's C. What's the point of the heart? It's supposed to pump blood. So if the heart's becoming, I know it sounds reductive, I'm sorry. If the heart's becoming infected, whether you're getting dilated cardiomyopathy, it's not working very well, your pump is not going to function, and thus you're going to see the effects of a lowly functioning heart. Mostly that's going to precipitate out in exercise intolerance. If it's a little kid, when are they most in their exercise? It's when they're feeding. So it's the feed intolerance. They can't finish a bottle. They're not going to finish a meal. They're not awake for very long, because awake is a form of exercise to these little kids. So it's the kids who are flat. It's the kids who aren't doing what they're supposed to be doing. So even if a kid's got a cold, generally give me the Norepinephrine, they're going to be able to run around, have a bit of fun, a bit of play. These kids don't. So when we see the predictable signs, fatigue, shortness of breath, fever's roughly half. Tachypnea, tachycardia, because the pump isn't working. When the pump isn't working, it backs up. So one of the very few predictable signs is actually hepatomegaly. Still only less than half, but it's something that I've unfortunately been able to use to pick kids. So it's about a third outcomes in terms of has complete resolution, has resolution with some impaired cardiac function or needs a transplant. And that's with the ones that actually die. Can we pick it on ECG? No, we can't. 72% of kids will have an abnormal ECG at presentation, which of course means that nearly a third will have a normal ECG at presentation. So having a nice ECG doesn't reassure you. It is that gestalt, it is the pump, it is the story. They're just not feeding right. Wasn't going to segue, but I had a kid, one of those ones you don't forget. Her name was Poppy. This was 10 years ago. And she came in, just cold, bit of runny nose, bit of fever. But one of my colleagues had said, Mark, I'm just going to hand this one over to you. Doesn't look quite right. Okay, noted. Went over, had a look, examined top to toe, tonsillitis. Clear, pussy tonsils, no problems. Just give her some Norepinephrine. If she can have a feed, she can probably go home. Had Norepinephrine, just kept sleeping in mum and dad. Tried to feed, didn't want to feed. No worries, it's just a bit of tonsillitis. Pop an NG in and we'll see how she goes. And one of the nursing staff came back and said, oh Mark, it was really weird. When I popped the NG into this kiddo, she just turned grey. And that was the light bulb moment. Kids don't turn grey, it's not in their story. Grey is C. Grey is part of the primary survey. Went out and actually examined the kid, found a massive liver and an ejection fraction of about 13%, which is ridiculous. Poppy recovered, but a lot of kids I've read about in my coronial reports. Okay, so the clues for myocarditis, the one thing that will really keep paediatric specialists like myself up at night is feeding intolerance, respiratory symptoms, shortness of breath. The pump isn't working, the kid isn't being a normal kid. 82% of cases have had multiple presentations to doctors, so if you miss it, you're human. But it's the story. If the kid just isn't behaving like a kid, even they look like I got a cold, like the only obvious symptom might be a runny nose. But if the kid isn't behaving like a runny nose because the story doesn't fit, then that's what we really need to learn. All right, we can move on from this. This is just a quick example on viral myocarditis. This X-ray, these two X-rays are from the same child, 3 days apart. This was a COVID myocarditis, came in, and you can see how rapidly these kids can present and decompensate. If the kid came in on the first day and had a normal looking X-ray and kind of after a bit of pantothenurine tolerated feed and they were sent home, probably wouldn't criticise you. Like we said, 4 out of 5 kids generally require multiple presentations before they cop to diagnosis. And so I wouldn't criticise. But listening to the story of this child where they weren't feeding properly and they were just overly lethargic and the parents had concerns, so 3 signs, led to the admission and the monitoring and the diagnosis. Okay. So, what kills kids? Sepsis, myocarditis do, and we do. I mean, we're all terrified through action or omission of harming a kid. So we can be involved. And cognitive bias is one of the ways that we unfortunately can miss things. So this obviously is the old trope of denial is not just a river in Egypt. The main form of bias, I reckon, is probably confirmation bias. And unfortunately, when I was rewriting this talk, I did read the 50 cognitive biases so I can be the very best version of me. I read them all, so you don't have to, and I am still very far away from the very best version of me. I've pulled out some of my favourites. Authority bias is something that the residents, unfortunately, are very victim to. The boss said it, so it's probably going to be fine. That's not right. We've got availability bias. We always go with what we know. So if the information is just right there to us, we're going to go with what we went with last time, with what's safe and easy. We all have our own blind spots, but all this talk of bias, we've been talking about bias in modern medicine for about 10, 15 years now. But despite huge attention to cognitive bias and we've got 50 types, we've got books being written, rates of errors have not gone down. So we can talk about bias till the cows come home, but we need to be doing something else with this new bias knowledge to actually have an impact on rates. And think about it, bias only exists when something's gone wrong. Bias and knowledge of bias is all retrospective. Bias is never prospective. I want to talk about a few little cases of bias and then I'm going to get to my main points. Ambiguity bias is something that always happens to me. I don't know what I don't know, and so I might miss something that way. It goes back to the old trope. More is missed by not looking than by not knowing. So it's the idea of just listening to this kid in front of you, having an idea, and if you don't know, get on Google. I get on Google most of my shifts at work. I've been doing this for a criminally long time, and I'm hopefully not too proud to say I still am far away from being the best version of myself, as the biases would explain, and I'm still learning every single time. The main one I want to talk about is anchoring bias. Anchoring bias is something that I think if we look back, we probably have all seen and probably been complicit with. I mean, I've been complicit with this. And I want to tell you a story about a kid called Declan. This was only 2 years ago. It was a post-COVID thing. Declan was a 10-month-old boy who was admitted through my ED with 2 diagnoses. The first was bronchiolitis. Okay, fair enough. You know, respiratory infection settles into the lungs. He had bronchiolitis. He had all the signs of bronchiolitis. He had all the crackles and all the chest, and he also had gastro. Those were his admission diagnoses. And it was true. Everybody at home had diarrhea and vomiting. He had diarrhea and vomiting. So he was hit twice. He was hit hard. He was only 10 months old. So he was brought in on an NG feed to help get through. But his admission diagnoses were bronch and gastro, and they did not change, although he changed. And this was where anchoring bias became diagnostic momentum. Oh, Declan in bed 1, he's got RSV, which was true. He had bronch, he had RSV, the GP in the community had tested for it. And he had gastro, everyone at home was sick. So Declan in bed 1, the bronch and the gastro, no worries. Okay, the kid in bed 2, and so on. The bias continues, the momentum continues, and we never stop to rethink. Does this still make sense? Is the story still correct? So this is the main point. I normally only ever verbal this, but probably just sick. Thank you. You know, if the heart rate, if the temperature comes down with Panadol Nurofen and the heart rate comes down accordingly, well then that's fine. The thing I read time and time again in the coronary reports is that kid comes into hospital, temperature's up, heart rate's up, gets Panadol Nurofen. Temperature comes down, heart rate does not come down. That does not fit with a story of a simple infection. That will often be the first sign of sepsis, which is what Declan had, or myocarditis, which is what Poppy had, and a lot of their peers. So this is the second slide. It's the same one, but with this blue line. You can see here, the heart rate, almost from admission, is up and stays up and stays up and stays up and stays up. And this is day 4, this is day 5, this is day 6 of infection. But kids, even with bronchiolitis, if it's a lower infection, you don't have to memorize bronchiolitis, but generally the story of bronchs are hard to remember. They get sick with a cold, the virus sinks into the lungs get inflamed. They basically just have their maximum work of breathing and distress days 2 and 3, and then they slowly get better. But he's getting worse. But the diagnostic momentum carried forth, and the diagnosis stuck despite the story not fitting. And even when we were reviewing this case, and this is why I really hate this slide, I hate that it exists, because we were talking about high flow. Oh, he had the bronchiolitis and he was getting worse despite all the high flow, all the oxygen we were giving him, he was just getting worse. Because the diagnosis was no longer correct. He was developing sepsis. If it was high flow on day 4, day 5, he really should have been improving. But the story didn't fit. Unfortunately, the diagnostic momentum and the anchoring bias precluded us from seeing this. So, persistent afebrile tachycardia, and I mean persistent. We've all seen a kiddo who, every time you try and go in to take a set of obs, they scream blue murder, so the obs always look terrible. Have a kid in resus, they've settled down, parent comes in with some macas, heart rate jumps up because the macas is there. Brilliant, fine. Persistent afebrile tachycardia is one of the things I will ask you to try and remember. I didn't want to have much new knowledge, but this is one of the ones, and this is not new knowledge, but this is what I will absolutely, if there's only one thing you take away from me jumping around and torturing residents, it's this. Persistent afebrile tachycardia, don't stop looking until you have an idea of what's going on. All right, a couple more viruses. Availability bias, is to judge things by things that spring to mind. We might have had it because we saw a recent case or we saw a TV show about it, that common things occur commonly becomes a self-fulfilling prophecy. Having a chat and listening to it, sometimes the story will tell you if you're wrong. A case which was really brilliant, a colleague of mine picked it up. He did a fabulous job. Kid comes in, virus, cold, cough, sore muscles. Okay, that's easy, that's flu. you have a bit of calf myositis, a bit of sore muscles, a bit of myalgia, no worries. And the parent said, yeah, every single time he gets sick, he can't walk for 3 days. Now, that's not normal. That doesn't fit any damn story. He ended up having a rare enzymatic problem, and every time he got a virus, he went into complete rhabdomyolysis. But the one story, I'm sick, I have a fever, my muscles hurt, I can't walk, that's easy, that's a flu story. But when the fuller story, the history was taken, this happens every single time, that's not normal. I don't expect anyone to pick an enzymatic mutation, but I do want my guys to go, that story doesn't fit. So I'm going to stop and ask some questions and maybe do some Googling. All right, this last one is just quite a cool one, deformation professionnel. We probably do it all the time. It's you go with what you know. So it's not the availability bias. If you have a headache and you see a GP, the GP say you've got a tension headache, you've got hypertension. If you have a headache and see a neurologist, you probably have some fancy migraine. If you have a headache and see a neurosurgeon, you probably have a tumour. So it's, you go with what your own thing is. So deformation professionnel, hopefully as ED people, because we see the broad range, we might be a little bit inoculated against that. Probably not. I mean, every single person who comes in agitated in my mind's had meth, but I don't know. All right. So what do? I've told you how easy kids can die. Not you guys. Hopefully we've gone upside down and inside out. How do we actually fix this? How do you get the vibe? How do you pick the kid before they curl up their toes and die? These are comments that I've taken from interviewing lots of my colleagues, lots of pediatric emergency specialists, about what clues you in your experience of 5, 10, 15, 30 years. How do you pick these kids? And these, all of the ones that I got. They're grey, they're pale, everything like that. They've got effortless tachypnea, all of these things, unexplained pain. Okay, you don't have to have a vibe. You don't have to remember this list, because if you rearrange the list, every single sign fits into the primary survey. Every single sign, every vibe, every experience that we got from the consultants over years, combined decades of experience, every single one just fits in the primary survey. So we don't have to have new knowledge. We don't have to memorize anything to pick a sick kid. This is not something you do by touching. From 10 feet away, you can walk over and in your mind, is there any adventitious noises to the breathing? Is there stridor? Are they working hard or fast to breathe? I don't even remember all the different observation limits per age of child, but does the kid look like they're going fast or hard? Do they have a normal colour or not a normal colour? Do they feel normally warm or do they feel too hot or too cold? Are they behaving normally? Because when they're in an ED, they're scared or they're interested. We're in scrubs or in the back of an ambulance is the best things ever. So if they aren't paying attention to you, that's weird. If they are irritable, if they have too much pain, if they have an altered cry, that's D. If they're pale, that's C. If they're breathing and grunting, that's B. If the parents are worried or if they're still flat despite their fever coming down, that's E. So we don't need new knowledge. We don't need decades of experience in pediatrics. All we need is what we know. And that's the main point of the whole thing. Okay. So all you actually need is a primary survey, the thing we use in our mind's eye every single day. Okay, so that's actually it. That's acute pediatrics in 45 minutes. I'm very happy to take any questions. I'm sorry to the residents for torturing you. But really, it shouldn't be too hard. Is there a question over there? Yes?
Fever, persistent fever at day 5, is that a continuous fever or, because some kids could have fever, it goes up, down, comes back.
I think it's fever that is present at least every day. So, I mean, yes, this has spun around once, but you're not febrile always. You do defervesce, which is a great term. So you get your fevers and they go away and then they come back as part of the same illness. So it's just consecutive days, not consecutive 5 times 24 hours, whatever, 120 hours. So it's just every single day because it's the kiddos who are developing probably the secondary infections. They've had their cold, their immune system is a bit busy fighting one thing, and then they get the secondary infection, the pneumonia, the empyema, a UTI, a bit of meningitis, something else going on. So it's those kids who have the prolonged fever. It's often one thing is becoming another. The basic stats are fever less than 5 days, 95% is going to be standard viral, about 4% roughly will be some form of SBI, serious bacterial infection, and that's usually going to be an otitis media, a UTI, a minor pneumonia, something easy to fix. Once you get over 5 days, the rates hit about 9%. So it's nearly 1 in 10 kids have got something on. So there's a lot of guidelines out there on the prolonged fever. And when I teach on prolonged fever, my basic idea is this. Some people say, oh, 5 days, let's do some blood tests. Well, kids hate needles. 5 days to my mind does not equal bloods, but it does equal thought. You just have to stop and look again and go, does this story make sense? Yes, it makes sense. You know, they were sick for 2 days, they went to 2 birthday parties, everyone snotted all over everyone else, and they're just sick again with another urti. You know, they've got some red eyes, red throat, red ears, and very clear lungs, and they look good after Nurofen. Well, that story makes sense. But if the story doesn't make sense, you're just using the thought now on the kid with the fever for more than 5 days. Pleasure.
Any other questions? Yes, up the front. I'll just run a microphone to you.
So what do you think about so from a general practice background, what do you think about just giving antibiotics, even if you think it was a virus to start off with?
I think the general paediatrician in me probably screams at that a little bit. Because, I mean, what are you treating? Are we treating parental concern? Are we treating fever? Are we partially treating? Like we know a lot of these kids will come in with you know, like partially treated pneumonias. And I don't know, is this a cold? Is this a partially treated pneumonia? Is it something else? I would probably advise against that. But I'd say that not working in the community. In ED, I'm going to have a kid for longer than 10 minutes. So I have more time to think. So I appreciate that it's very, very hard. And I don't have to do that job. I only have to see kids. I don't have to see adults as well. So the idea of blanket, I'm not quite sure what it could be. I'll give you a script for antibiotics. I do think is probably not ideal. A middle ground would be, here's a script for antibiotics. It's probably just a cold. If it doesn't improve in the next sort of 36 to 48 hours, or if any of the signs are getting worse, the breathing is getting harder, the cough is getting worse, the fevers aren't going away, then please by all means fill the script. But I wouldn't do it just on the day because we know so many, well we know 95%, if they've had a fever less than 5 days, 95% will have a benign viral infection of no consequence. And it's only 1 out of those 20 will have a problem. So I absolutely appreciate a parent is worried and they need something from you. I can give them time in the hospital, which you can't. But if I would say middle ground between where I am and where you are would be to provide a script, but with very clear instructions of when and when not to fill it.
Anyone else feeling brave? Yep.
Just in regards to the triage, like the tickles, work of breathing, and circulatory assessments, has that been like built into like a triage system in your hospital? Is that something that's drilled in as far as the primary survey goes? Because I'm from a major tertiary hospital, and that's drilled into us from day dot for nursing staff at paediatric triage, and that is part of our assessment, and that's to avoid sentinel cases. So just interesting.
To my knowledge, the education around paediatric triaging in my hospital, which is an outer metro secondary centre in Melbourne, but a busy outer metro centre, I should have introduced that when I started, I apologise. To my knowledge, that isn't sort of drilled in terms of, this is what you're looking for and it's what you're documenting every time. That being said, our guys are very attuned to just like applying the Australian triage scores, the ATS, very rigidly, and we have so many kids who are Cat 2 because they are febrile and tachycardic, and they are febrile and tachycardic just because they have a cold, and that's always okay. They come in, they have some Panadol Nurofen, they defervesce, their heart rate goes down, they eat a biscuit and an icy pole, and that's all fine. So I never roll my eyes when, yes, it's another Cat 2 for fever and tachycardia. The interactivity and the consolability is not drilled into the triaging staff where I work. However, they often give me a call as the paediatric emergency physician on to say, I don't like the look of this one. So I think they're working on the vibe versus working on a formal induction sort of system, but I think it's probably something we could improve a bit.
I just want to make a comment from the adult world about group A strep. It's also been resurgent in adult population, and the research with people who have COVID who got a secondary bacterial infection, group A strep was the second most common organism isolated, which just wanted to add.
What was the most common?
Staph aureus.
Staph aureus, yeah, so staphs and streps, yeah. IGAS was a big thing in paediatrics and adolescents. There was a lot of deaths, adult and paediatric and adolescent, through Australia, and quite a lot documented through the UK as well in the post-lockdown sphere. So yeah, a lot of these, and I think the principles apply, like, you know, low natural immunity, low immunity for the primary viral, and then sort of more virulent strains of strep and probably the same virulence of staph, which has always been a nasty bug. So I think the principles, thankfully, apply still the same. And there's always something to watch out for.
All right, unfortunately we're going to have to call the questions there, so let's have a big round of applause for Mark.